Okay, thank you for joining the lab interview. This is all about new data about antithrombotic, and our co-moderator is Dominick, Angiolillo, and the co-panel and Dr. Pieter and the Dr. Tullio. Okay, go ahead.
Yeah. Well, thank you. Thanks for the introduction. So we had a very nice session about the newest data on antithrombotics. I would like to start off asking you, Pieter, a question as it relates to definitions. We know for many years there have been so many different definitions, very different opinions. So tell me a little bit about these unified definitions and what does ARC mean and what's the latest in ARC?
Thank you, Dominic. Well, first of all, I totally agree with you that, for instance, on bleeding, we had a huge amount of bleeding definitions. I think we can add up maybe 9 or 10 of them, and which was a huge heterogeneity in definition. And some only looked at laboratory results, and others looked at only at clinical events, and others looked at a combination. So there was really difficult to compare strategies or therapies and drugs with each other on the bleeding events. So in that respect, the ARC initiative, and the ARC is a voluntary collaborative of all the stakeholders in clinical research, like trialists, industry, regulatory institutes like the FDA. They come together and they try to come to a universal definition of some endpoints. And one of the greatest, I think, consensus meetings that have been there was the ARC definitions on bleeding, showing the BARC classification. I think that is now quite widely adopted throughout the field. And I think that has been a huge advantage in getting a more universal classification on bleeding. So I think that is one of the greatest advantages of ARC so far.
Right. So one of the latest ARC documents, Tullio, has been that on modulation of antiplatelet therapy, because for years we've been using so many different definitions, and at some point we say, well, we need to speak the same language. So what can you tell us about the latest ARC definitions?
So very important point. Now when we prescribe antiplatelet therapy to patients after acute coronary syndrome or PCI, we face 2 problems. Prevention of ischemic events without increasing bleeding events. It has become clear that not all antiplatelet strategies fit all patients. So one size does not fit all, and it has become clear that we need to tailor antiplatelet therapy according to the patient risk profile. So in this regard, modulating antiplatelet therapy, meaning intensifying or decreasing the intensity of antiplatelet therapy, has become an issue of primary importance. And there have been many trials talking about the escalation antiplatelet therapy, escalation of antiplatelet therapy, but there is not a consensus on the meaning of escalation and de-escalation. Now, as you were saying, there is a consensus definition according to which escalation antiplatelet therapy means intensifying the potency of antiplatelet therapy, and this can be achieved by switching to a more potent drug, increasing the dose, or adding on standard antiplatelet therapy. On the other hand, de-escalation antiplatelet therapy is defined as reducing the potency of an antiplatelet regimen, and again, this can be done by switching to a less potent drug, or by reducing the dose, or discontinuation of antiplatelet therapy. And I think this common language may help in interpreting the data of the randomized trial that have been performed and of the randomized trial that are going to perform.
Well, perfect. So changing the drug, the dose, and the number.
Exactly.
So I'm going to focus on the last part, the number of drugs. Okay, and I'm going to go on de-escalation. So we have the traditional view of de-escalation, which is stopping the P2Y12 inhibitor. But now we're speaking about stopping the aspirin and continuing with P2Y12 inhibitor monotherapy. And so maybe an opinion from both of you.
Yeah, I think that the first critical issue is whether all P2Y12 inhibitors are the same. So if it's right at this point to talk about de-escalation to P2Y inhibitor in general, or if we should differentiate between ticagrelor and clopidogrel. I'm very confident that there are enough data to say that de-escalation to ticagrelor monotherapy in patients with acute coronary syndrome is safe and effective. There are many trials that have shown that you reduce bleeding and you don't pay a price in terms of increasing the ischemic risk. And there are also some meta-analyses that suggest that this trade-off may turn out in a reduction in mortality. So I'm not sure that at least within the first 6 months, de-escalating to clopidogrel would be the same. There is a large recent meta-analysis that suggested that clopidogrel monotherapy may reduce the risk of bleeding, but it is maybe not inferior in terms of ischemic events. I mean, this is a data that should be better specified. It's an initial data, but this is the finding. So I have some concern in switching to clopidogrel after first 6 months after PCI, unless you don't do genetic or platelet function test.
I have one comment for Dominick and Pieter, and we are different country, and we are talking about the escalation, de-escalation. My question is about how much frequently using guided the moderation. You plate function testing or genetic testing in South Korea. You know, a couple of years ago, 5 years ago, 10 years ago, we are widely used genetic test, P2Y12, the polymorphism or plate function test like a verify now test. It's just a little limited center using that, guided some measurement. How frequently use it in your practice?
Yes. So at our center, we use a lot of genetic testing. I can say we do genetic testing in every patient. It started off originally as a research project, and then the research project next phase was as a research project, do it in everybody, and now we continue to do it in everybody. And the advantage is obviously that genetics do not change. We also have the issue, not as big as in Asian populations with loss of functional alleles, but we have a very large African American community. We have patients who are frequent flyers in our cath lab. And since the genetic information is in electronic medical records, it's there. And it's there for the physician to know about it. Because we also have the issue that now Proster is generic, but there's a lot of ticagrelor, which is expensive. So if you want to de-escalate to clopidogrel, you want to make sure that the patient does not have loss of function. So we do it in everybody.
Good.
Well, maybe for research purposes, it's nice to do, I think, and could be very interesting. But in clinical practice, for instance, in my institute, we don't do it at all. Also because the evidence to show that will have benefit is not so clear. It does not show that you will, by doing the genetic testing and by altering your therapy, at least for the Western European community, it does not show that it has shown much benefit. That I think is the major reason, I think, why at least we, and I don't see institutes around Europe as well not doing it.
Is Tullio?
I agree totally with Pieter. We don't use genetic testing or platelet function testing. But again, if the tendency will be that of de-escalating early to clopidogrel monotherapy, I think that they will become important because, again, you have a patient 3 to 6 months who is not on antiplatelet therapy but clopidogrel, and you want to be sure that clopidogrel is working. This may be less an issue later, probably after 1 year, because there are some data that without genetic testing and platelet function tested, clopidogrel monotherapy may be better than aspirin. But the issue is that we are after 1 year, so we don't have stent-related issue, and therefore resistance to clopidogrel may be less relevant.
So my another question about beyond the 1 year after stenting is a long-term maintenance therapy. Is aspirin versus clopidogrel is one of the issue, and our host exam trial conducted in South Korea showing the clopidogrel is better in terms of efficacy and safety outcome. After release of host exam trial in the published in Lancet journal, in our real practice, the many center reflects is clopidogrel. Price is clopidogrel is 7 times, 8 times much high price, even though the many physicians believe clopidogrel is better than aspirin alone. Is a host exam impact in the U.S. and on Western country? How do you do? Is after stenting, it's just monotherapy. Could you select aspirin mono or clopidogrel? This guideline just recommended the class 1 recommendation aspirin monotherapy.
Yeah, well, the host exam was an excellent trial, and it's almost a replica in modern era of the Capri trial. So now we have 2 confirmatory trials. I can say, however, in the United States, aspirin remains still long-term the drug of choice. We do believe that there is a need to conduct a similar trial to host exam amongst Westerners. It's not that we don't believe in the trial; I think it's an excellent trial, but I do believe that we need to conduct a trial of our own as well.
Yeah, I agree. Also, in Europe, at least in my institute, we keep on using aspirin as monotherapy after 6 or 12 months DPT in our PCI population, and it's difficult to change that because aspirin has been there for so many years. It's very cheap, and changing it to clopidogrel, showing in your host exam trial, could be definitely beneficial. But I don't see the uptake. It's really hard to take out the aspirin out of the pen of the physicians. It's really hard, and maybe we need more data. At least the neurologists, they managed. They managed to go from the low dose aspirin. They switched to clopidogrel. So for the stroke treatment, it seemed to work. But I don't know why it doesn't work that well for the cardiologists at this moment.
So I think we definitely need data in the Western population because we know we are aware about the Asian paradox and the fact that Asian patients respond in a different way to antiplatelet drug as compared to the Western population. So they have a higher risk of bleeding and a lower risk of ischemic events. So what may be true for the Eastern population may be not for the Western population. So definitely we need data, but I think may be a promising alternative.
Yeah, I think we're gonna change the gear in the next future perspective. Last talk is about the factor 11A inhibitor. This is absolutely booming in the Dominick and the Pieter and the Tullio make some big milestone about the optimal antithrombotic therapy in the ACS and PCI population over the last 2 decades. So how gonna you in aspect of expert in this field, how do you expect this factor 11A is how much change our practice?
Yeah, so first of all, I think the science behind the factor 11 is unbelievable. It's very promising. But unfortunately, as we learned from the oceanic AFib, it was stopped prematurely because the drug wasn't effective. So the promise of having a target that reduces ischemic events without bleeding we start to think maybe it's not as effective. Maybe the dose was wrong. Maybe the population was wrong. We don't know. I still have a lot of hopes with milvexian in the AFib patient population. But again, we have to keep in mind that we are comparing it with some very, very good drugs, which are NOACs. And NOACs are very, very good. In the ACS patient population, I think the main issue is going to be the uptake, because we've had other strategies, for example, low dose for rivaroxaban. They worked, but nobody uses it, because then it's a concept of a triple therapy, and we don't want to do that. So we'll see. If the trial data really need to be overwhelmingly positive, in my opinion, but only time will tell. This is my personal opinion.
And mine as well. I think that you looking at the numbers of to treat in order to get a reduction on ischemic events and in bleeding events is really hard to get. You really have to do huge trials to show those differences between now this factor 11 agonist and the NOACs. I think it's going to be hard. I have doubt whether there will be a adoption, mainly because of economic reasons. I think NOACs will go out of patent and will be cheap to prescribe, and those new drugs will be expensive. And there's already a huge burden on even in Western Europe, rich countries. There's already a lot of debate about how much healthcare cost is really pressing on our budget, on our economic and daily budget. So I'm not so sure if we have to take that into account as well. I think the economic factors.
How do you think about it?
So yeah, the mechanism of action of this drug is really appealing, because they may reduce the risk of thrombotic events. So they may uncouple the risk of thrombotic events and the risk of bleeding. So reducing the ischemic events without increasing bleeding. But this is just physiopathology. So we need for sure clinical data. I think that uptake for low-dose rivaroxaban across the world has been not a great uptake, just because it increases bleeding, increases major bleeding, despite the fact that reduced mortality, and this is to me the most important endpoint. But for some reason, this result on the bleeding effect probably has dominated, and is the reason because of this low uptake of low-dose rivaroxaban in patients with coronary artery disease. Of course, I mean, if you have, if this would not be the case with this new drug, probably they may have success.
Yeah, I think conceptually, factor 11 inhibitors, some decoupling ischemic risk and bleeding risk, just while preserving bleeding risk, just lowering the ischemic risk is theoretically, I think, reasonable. But this, in real practice, nobody knows. Is it the absolutely clinically applicable in the real world population?
Well, we'll see. I mean, the first thing is let's look at the clinical trials, and we know that clinical trials do not represent real world either. But it's exciting. I think that the fact that we have a lot of trials actually is a good thing, because there could be consistency in one direction or the other. So I like it when there are a lot of trials in the field. And as you mentioned before, some companies may go bankrupt. But I want to stay somewhat positive, because there's so many trials going on, and maybe we will find a niche population where these drugs may be beneficial.
So I think this is the real point. There are many variables that you should consider on how to use this drug. Are you using this early or late, on top of a dual antiplatelet therapy or in conjunction with a single antiplatelet therapy? So probably there may be a combination of variables in which this drug may turn out effective and safe.
Yeah, good. So I think and this discussion session is many audience learned a lot of things. What is the cutting edge knowledge about the new data about antithrombotic therapy? And thank you, is co-moderator and the panel, and I would like to end up this session. Thank you very much.